إنك organize this. إذا كان أنا connecting through my personal hotspot فإذا في connectivity problem please you can call me right away عشان I fix it.
ولا يهمك.
شكرا. في هذا ال presentation عندنا two main topics, basic topics. واحد منهم cystic breast lesions and then the one afterward will be about breast calcifications. We'll see how the time goes. Either we take a break in between or we just go in one go. بعض السلايدز هنا will require some participation. فإذا أحد منكم جالس يسوق في السيارة وبس قاعد يسمع I may pick randomly some names. We'll start with the first topic اللي هو cystic breast lesions. The outlines of the lecture includes just some basic terminology about the BIRADS, about how you report, and then we'll go through the cystic breast lesions, and we will afterwards go through breast calcifications. In between the topics, we will have some cases. Before we start by assessing the lesion and describing the imaging finding, we have to go about the reporting, to talk about the reporting. طبعا you know that the most commonly used modality to assess a breast mass is ultrasound. We can see the mass on mammogram, or the patient can present with a concern, and the best modality, the first best modality is going to be ultrasound. So when we are going to talk about reporting, we need to write the indication of the exam. And in the indication, we need to mention the patient's age, because the modality differs according to the patient's age, according to the ACR appropriateness criteria. And we need to know if this finding was found, this mass that we're going to describe is based on screening ultrasound, mammographic finding, or this is based on a palpable concern by the patient. You need to write all of this clearly on the first part of the report. And if the patient is presenting with a palpable concern, you need to go yourself to the patient, speak to her about this palpable concern specifically, since when it's been there, and has it been growing? Is it stable for a long time? After you take the appropriate history, you will ask the patient to point to the area of the abnormality or where she feels the abnormality. You will do your physical examination yourself, and then you will do the ultrasound. Why do we do the physical examination ourselves? Because you will add that part to the report. You will say that during physical examination, a palpable mass was felt, or sometimes a lot of patients come to us and the palpable concern is not appreciated by the physician. Sometimes it's related to breast parenchyma. So you will not say this is breast parenchyma and that's it, you conclude it. You can say that on physical examination, the mass was not appreciated, but you will still examine over the area of concern. Okay, so just a quick quiz. Now you'll go to the room and you will do the ultrasound. Which probe you will choose? أهلا أنوار.
أقدر أجاوب؟
إيه.
superficial اللي هو high frequency transducer.
ممتاز. في another option. ترى أنا ما أشوف الشات فأرفعوا يدكم زي أنوار. في أحد يقول لي الصوت ضعيف. الصوت كويس الحين؟
كويس دكتورة.
طيب أوكي. طيب في another option other than high frequency. We know it's high frequency بس في range أحيانا يعطونك إياه في الفريكونسي. High frequency means what? Frequency of at least 12 or frequency of at least 2.
أقدر أجاوب تخمينيا.
إيه لما تقولين high frequency شو يعني high؟
well,
يعني
at least
12 ولا 2؟ يعني number wise.
بحكم إنه 12 أكثر فبقول 12.
اوكي صح، فهم يعطونك رينج، احيانا يقولون لك في some notes 7 to 12 بس يعني البيك او احيانا 7 to 15 بس you will go towards the higher frequency lower frequency this is the one that's used for the curvilinear probe or lower frequency transducer which we can use for deeper structures. Sometimes if the patient has a huge breast the abdominal transducer or the lower frequency transducer may be of use, but not we don't use it routinely. Okay, next. شكرا أنوار. طيب, now we go to the findings. The main findings on ultrasound, according to the BIRAD lexicon, are masses or calcifications, and then there are associated features. There is another finding, it's called non-mass area. This is not included in the BIRAD lexicon. It might be included on the upcoming lexicon, but it means that you do not see a specific mass, but you can appreciate that there is a different area of breast tissue different to or altered ecotexture different from the remainder of the breast. And it does not qualify as the shape of a mass. And some of these findings, for example, most commonly invasive lobular cancer, can present with non-mass area. Now going to describing the findings. As a resident, you must have access to this card, have it with you in your room or in the background of your whatever device you have when you are reporting, similar to mammography. I still use it as well. So you have to describe the findings starting by the shape, and before the shape, we describe also the clock area or the zone. And when you go to describe the mass, you try to stick to the terminology as long as you are a resident or a trainee. You can say either oval, round, or irregular, and there is an acronym that helps you memorize it. It's called ROI. There is another new shape that will be introduced, not yet. It's called lobulated. So for exam purposes, you have oval, round, and irregular, and then you will go about describing the mass, the margin, and etc. The echogenicity of the mass. How do we define the echogenicity of the mass? So it's you describe it relatively to the fat, the breast fat. And when you describe it according to the echogenicity, you will know the nature of the mass, whether solid, cystic, or mixed. Right. So after you define it by the echogenicity, you will know if it's solid, cystic, or mixed. Do you see the entire screen, or do you have the participant window showing? You don't see it, right? Just the screen, Laida?
السكرين واضحة عندنا دكتورة.
ما في participant window صح؟
لا.
طيب. طيب R1 or R2? What is this finding? Abdullah al-Bakri.
أيوة دكتور معك.
What is this finding, Abdullah? Did you do any breast rotation ولا لا؟ إذا you didn't do it خلاص. بس يعني it's the same finding that you will see in different.
سؤال صح بس الألتراساوند صراحة ما أعرفه.
طيب if you see this in any organ.
كان في كده shadowing من السيستيك هذه component posterior shadowing.
posterior shadowing هنا ولا هنا؟
لا اللي خلفها على طول.
هذا؟
أيوه.
اوكي اوكي عشانك ما سويت بريس اتس اوكي. فهذا عندنا الchest wall. طيب غدير.
أيوة السلام عليكم.
أيوة غدير عليكم السلام.
Okay, so this is an oval shape, an echoic mass with well circumscribed margin associated with posterior enhancement, most likely related to simple cysts.
طيب most likely ولا it is a simple cyst?
It is.
Okay, so this is compatible with a simple cyst, صح? It has all the criteria of a simple cyst. What's your BI-RADS?
2.
Okay, excellent. طيب. What about this finding with the arrow?
I think that fluid level.
Okay, ممكن صح واحد من differential. في another participant who would like to take another guess? Okay, this is an artifact. What's the name of this artifact?
Reverberation. Reverberation artifact.
Reverberation artifact صح عليك. هذا artifact might be mistaken for a solid component أو a thick component within a mass أو زي ما قالت لنا غدير ممكن أحد يحسبه fluid level. فالanterior portion هو you have to study the physics unfortunately but it's caused by two high reflecting surfaces. In this case I think they mean that the anterior the wall of the cysts, and you will have an area of echogenicity. Usually the area will be in the anti-dependent portion of the cyst. If you think that there is a fluid level, you can turn the patient, you can assess the vascularity, and one of the exam questions or things that you read is how to correct this. You can say using tissue harmonic imaging. فهذا similar to other artifacts that are seen elsewhere in the body. For example, one of the examples is the comet tail artifact that you are familiar with. طيب we have مثل ما ذكرت زميلتنا simple cysts. You have to have a criteria for simple cysts. It has to have circumscribed margin, be anechoic, round or oval in shape, thin imperceptible wall, has posterior enhancement, no internal vascularity, and if there are septations, they must be less than 0.5 millimeter in thickness. Is it always easy? No, it's not always easy. مثل لما يصير في عندنا artifact similar to the case that I just showed you. Sometimes it cannot be easily differentiated from a solid component, and it may undergo biopsy. Other areas that are difficult to diagnose a simple cyst is if the cyst is located in deep location in the breast or it is small in size. And some very hypoechoic solid lesions may appear as anechoic, sometimes because they are high growing and rapidly growing, and they have some necrotic center, which is cystic. And it's very important to keep that in mind because these findings are associated with the presence of high-grade carcinoma or the triple negative cancer, and they may also exhibit other features of a cyst, such as posterior enhancement. The good thing is most of these cystic appearing invasive cancer can show at least indistinct margin or some thickened wall that will allow you to differentiate, or some internal vascularity. Okay, so when you have a patient presents, you have, for example, screening ultrasound, or you do ultrasound for any other reason, and you have multiple simple cysts, you do not have to report every simple cyst in the report. You just mention the location and measurement of the largest cyst in each breast. For example, you'll say multiple cysts scattered, the largest is located, similar to when you are reporting renal cysts. For the mammogram, if you have multiple bilateral circumscribed similar appearing masses, and what do we mean by bilateral? Bilateral, we mean that there is at least 3 overall and 1 in each breast. This one of the few things that we can dismiss on a baseline screening exam, and we can give it by RATS too. But they have to be circumscribed and they have to be similar appearing. Some of the cysts may demonstrate some calcification, and if you do a lateral view, you may see that this calcification layer. Okay, what do you think of this mass? أنوار، أنت رافعة يدك ولا من أول؟
لا الحين رافعة يدي.
Okay.
Okay, so I'm looking at a rounded hypoechoic observation with posterior acoustic enhancement. I don't see any solid lesion or solid internal components or any calcifications.
Okay. طيب observation هذه عادة نقولها MRI حقت الليفر ولا CT الليفر. احنا هنا ما نقول observation، نقول a mass anechoic lesion. يعني ما نقول حتى lesion، نقول mass.
Okay.
طيب ايش رايك فيها هذه؟
It is well circumscribed. ما أشوف
What do you want to do?
بحط عليها دابلر.
Excellent. طيب حطينا عليها دابلر.
There is internal component افترض انه مو artifact with seems like hypoechoic septations أيضا.
Okay صح، في vascular component وفي wall thickening، وهنا عندنا elastogram that we do not routinely use. I actually never used it, but it can tells you the hardness of the mass. The red will tell you that this area is soft. Blue is telling you that it's harder. It's not a cyst, right? It's a mixed cystic and solid mass. This highlights the importance of the Doppler exam. And also without the Doppler, you can suspect that these margins are a bit irregular and there is some echogenic rind around it. So if you don't do the Doppler, you may think this might be inflamed or complicated cyst. What do you do now? What's your BIRADS?
Since إذا هو screening بخليه BIRADS 0, I will do further imaging.
Screening. عادة لما يجون for screening يعني قصدك screening and you didn't check the case. عادة screening ultrasound في there's someone to check the case. فلما أحد يجي screening ultrasound لازم نعطي BIRADS للcase. Is it suspicious based on this finding ولا لا؟ But let's say that there are certain settings where they do automated breast ultrasound screening. And you have this finding. What's your level of suspicion, high or low?
High level of suspicion.
Okay, so you can write your BIRADS based on it, without waiting to call the patient back. So this is very suspicious. It's BIRADS 4, and this was triple negative breast cancer, and the patient had a palpable mass. So we cannot give her BIRADS 0. Good job. This is how simple cysts appear on MRI. We have here the T2 and here the post-contrast, but not subtracted. They will have a variable degree of T1 signal intensity, depending on their composition. And the cysts are allowed to have a peripheral thin enhancement. Okay, this is another case. This is a patient who presented with pain, and this was her mammogram. I'll choose a name. فهد الحمد. فهد الحمد KFMC رياض.
Can I take the case, doctor?
أيوة you can بس خلينا نشوف فهد الحمد. طيب إذا أحد مو موجود ترى there is no point of showing your name. You can exit the meeting. مين اللي قال can I take the case?
It's me, doctor.
لميس? Okay.
Hey.
طيب بس quickly what do you see and what do you want to do next?
Okay, I'm presented with a selected image of left breast MLO view. I'm seeing type C breast density, which may obscure masses. There are multiple iso to hyperdense, partially obscured round masses scattered all over the breast. Next step, I might do spot compression for the masses that I suspect, or complete with ultrasound.
Okay, good job. If you describe them as masses, you can go straight to ultrasound unless you have suspicion that they might not be masses, or if you want to define the margins, but you can do that with ultrasound. So you can skip the additional mammographic views and you can do the ultrasound. So you have these variable pictures of ultrasound. What
I'm
do they have? Lamis? Okay.
Yes, so I'm presented with multiple hypo or anechoic masses with internal echogenic foci. Some of the masses are hypoechoic and some show leveling. The masses, the larger ones, appear somewhat lobulated, so I'm suspecting a case of complicated cyst with internal debris.
Okay, ممتاز. فهذه these are pictures of multiple masses. All of them qualify to represent complicated cysts. محمد العنزي, ممكن you mute yourself? وعبد المحسن الخلف. They have variable degrees. They show different findings, but all of them are complicated cysts. The first one, here you have these echogenic reflectors, and these can be mobile at the time of real-time evaluation. The other images, they show oval circumscribed masses with posterior enhancement. There's fluid debris level in here and in this one. You can turn the patient to see that this debris, this level is mobile or shifts according to the patient position. And this is here, the one with the arrow is an example of uniformly hypoechoic mass. Also in the presence of adjacent or similar appearing or other cysts in the breast, this is most likely a complicated cyst. Complicated cysts, their definition is cysts that contain debris, proteins, milk, fat, or pus and blood. And they meet the sonographic criteria for simple cyst, but they're not anechoic on ultrasound images. Debris, any of what I just showed you qualifies as BIRAT2. Now, there are different scenarios. If we have isolated complicated cyst, meaning just a single one with uniform low-level echo, like similar to this one I showed you here, This can mimic sometimes a solid mass, so you can recommend follow-up and give it BI-RADS 3. If the cyst is palpable, then it's BI-RADS 4. If there are other suspicious features, like associated vascularity, thickening, or irregularity of the wall, or change in size at follow-up, these may require further investigation and biopsy. So these are the MRI images of how different composition of the cyst may present. In the top image to the left, you have this T2 hyperintense cyst, and posterior to it, you can see another cyst, which is dark on the T2 sequence and a bit bright on the T1 without contrast, probably due to its component. And when you give the contrast, they both show similar enhancement pattern peripherally. So probably the one posteriorly is a complicated cyst, and this is BI-RADS 2. Okay, who wants to tell me the diagnosis? Patient with the screening ultrasound. Just the diagnosis, nothing else.
دكتورة ما أعرف كيف يرفعوا يدهم بس
Speak up,
Okay.
you don't need to raise your hand. بس
okay تمام. So I think إنها ممكن تكون complex cyst
complex. ليش؟
لأنه فيها كثير septations. أنا ما أتأكد إذا هذه solid component كمان
طيب.
أو ما أدري يمكن أقيس السبتيشن يعني إذا صغيرة ولا كبيرة.
Okay, ها صح عليك. It's not a complex cyst. فهي multiple small cysts وفي بينها septations that are extremely thin. فهذه كلها are thin septations. أحيانا when you are taking one picture, it may mimic or it may give you a wrong impression that this is a thickened wall. But when you go on other reviews, you will see that they are all thin. فمع كل هذه الكاركترستيك اللي أعطيتك إياها إيش الاسم؟
I think إنها clusters يسموها أو شيء clusters.
صحيح. فهذه is part of the spectrum of benign cystic changes, and if it's very clear, you can give it BI-RADS 2. You don't need to do any follow-up. Similar to the simple cyst, if you cannot definitely localize it, meaning if it's small, describe it or define that it's a cluster of cysts, meaning it's either small or deeply located, you can recommend follow-up. If there are suspicious findings, as we mentioned before, for example, on mammogram, not only on ultrasound, like this area there is suspicious calcification, then you will need to do a biopsy because of the associated suspicious findings.
Doctor, I have a question.
Yep.
How can I differentiate between clustered microcyst and fibrocystic changes?
Fibrocystic changes is a pathological diagnosis. Clustered microcyst is an imaging diagnosis. If you go and biopsy this thing and the result says fibrocystic changes in pathology, then that's okay, we can diagnose it this way. But the term fibrocystic, we can suggest that, for example, multiple clusters of cysts may suggest underlying fibrocystic disease of the breast, but as an imaging diagnosis, we don't describe this as this is a fibrocystic mass. Okay, Damis?
Yes, thank you, Doctor.
My pleasure. طيب, which one will you biopsy?
The one with the arrow?
مين هذا الجواب؟
أنا معك غيدا دكتور
غيدا. أوكي, ليش؟
عشان فيها internal soft tissue echogenicity في dependent area suspicious complex cyst need biopsy
I agree with you. Is there another one that you'd like to biopsy?
The one on the left, maybe the septation is thick.
The upper or the lower
The,
one?
the upper one.
Yeah, margins are irregular. This is suspicious. It doesn't qualify as a benign or BI-RADS3 finding. Septations هنا ممكن you question some of them are thickened, but the most suspicious here is the ill-defined margins and the echogenicity around it. This was breast cancer and this was an abscess. And the third one was a cluster of cysts, which did not need biopsy. So now we go to the complex cystic and solid masses. So as the name implies, these are masses containing both anechoic and echogenic component and may have one of the following: thick wall, equal or more than 0.5 millimeter. If it's less than 0.5 millimeter, we can call them as thin septations, similar to the septation. And if there is a complex, or if there's a solid component, intracystic or mural mass. They have different causes, including benign, probably benign, and malignant causes. Benign causes that can give you a complex cystic and solid mass include an inflamed or ruptured cyst, or sometimes a cyst that collapses and decreases in size, may give you the appearance of a complex cyst. Abscesses, areas of fat necrosis in the appropriate clinical settings, seromas, hematomas. Probably benign causes include, probably benign causes of complex cystic solid masses. If you think that something that's related to fat necrosis or inflamed cysts, you have to make sure that your recommendation of follow-up, short-term follow-up and not long-term follow-up, is very clear. And you also have to say it to the patient, not only in your report. So it does not qualify for the 6 months follow-up that we usually recommend. And you have to do a short interval term follow-up. For malignant causes, we have poorly differentiated cancers, some subtypes, medullary or mucinous. We have papillary lesions, whether benign or malignant. Is this a complicated cyst or a complex cystic and solid mass?
Complex.
Okay, your main differential here? Cysts with a solid component. Without the Doppler, you might think that this is maybe a blood clot, debris, but with the Doppler, you have to give a differential of a solid lesion. Do you have one differential in mind?
Intraductal papilloma.
So papilloma can present with similar imaging features, and whether benign or malignant. So this was a case that has DCIS within the papilloma component. Sometimes we can call them, if they are encapsulated within an area, we can call them encapsulated papillary carcinoma, of course, after the tissue diagnosis. Okay, what about this case? We have this mass here. Maybe an R4 or R3.
Can I take it?
Lamis?
Yes.
Okay.
Okay, so I'm presented with selected images of ultrasound. I can see that there is, I think it's a dilated duct with a solid or soft tissue component, as well as vascularity seen, which I would suggest it's at the stalk, so it's an intraductal papilloma.
اوكي طيب أول شيء قبل لا نقول it's a dilated duct أول شيء we need to describe it. We describe the finding and then we say this is most likely dilated duct. This is a mass here, right?
Yes.
You can say maybe you can say circumscribed or you can say indistinct, depending on how you see it. And there is this cystic component within it, right? And partially what looks like maybe solid. It's heterogeneously hypoechoic with mixed echogenicity. You can describe this in detail. Doppler, yeah, there is a vessel around it, but there is nothing within it. Just a moment, okay? Yeah, I'm back. As a definition, you can describe it as a complex, solid, and cystic because the wall is thickened here. And this patient came for something else. She had an asymmetry on ultrasound, and incidentally, we found this finding. So on these images, are they suspicious or not, Yalamis?
I think it warrants by reds for it is suspicious.
Yes, on these images, it is suspicious. But as we said, we have to go examine the patient ourselves. We asked the patient, did she have a recent trauma or injury? And she said she had a recent accident. We did a mammogram. I'll show you the mammogram. What do you think? This is a right CT.
The round centrally lucent mass retroareolar in the right inner quadrant. I think there is some peripheral calcification as well.
لا طيب أول شيء this is a tomosynthesis صحيح? It's not the synthetic 2D mammogram. You can see here from the periphery of the image that these are some slices. Yeah, there are no calcification. So this is lucently a mass with a lucent center. فإحنا we labeled it as 12 o'clock. It was around this area. It may be close to it. Does it correlate? Do you think it correlates with the finding that we saw?
Yes, it does.
In terms of location?
Yes, it does.
Okay, so your final diagnosis would be
Fat necrosis.
صحيح, fat necrosis. The patient had the increased echogenicity sometimes are seen with fat necrosis or hematoma. So the patient had a large area of bruising few months before her presentation. If we did not do the mammogram and the patient gives us this history, then we can call it probably fat necrosis, short-term follow-up, and for example, 4 weeks to ensure that it's resolving, whether it's hematoma or necrosis is recommended. If it's not resolving and we still did not do the mammogram, then we can do the biopsy. But now that we did the mammogram, this turns into a BI-RADS 2, and we do not need to intervene. This is just a summary of the cystic lesions. If you have a simple cyst, you just go to BI-RADS 2. Clustered microcyst is also BI-RADS 2. Whenever you have a lesion that's not well visualized, you can recommend follow-up. And when we go to the complicated cyst, these are BI-RADS 2 unless they are isolated with uniform low-level echoes. Then this is BI-RADS 3. But if this finding is palpable, then this is BI-RADS 4. And any cystic lesion with the criteria that we mentioned will go as complex cystic and solid mass and prompts a biopsy. Most of this talk is from this article. I recommend that you guys go to the radiographics article, the residents or trainee section, and take a look at all the articles whenever you have time. This is the first part of the lecture. عندكم سؤال, you can speak up.
واضح، شكرا.
طيب نروح للكلاسيفيكيشنز عشان تخلصون وتروحون ولا تبون بريك؟
مو مشكلة دكتورة، نقدر نكمل بعد، يعطيك العافية.
طيب let's go to breast calcifications. طيب calcifications are easier sometimes because they are either typically benign or suspicious, and in few circumstances they are probably benign. فعندنا typically benign calcifications, you know them, the vascular, skin, dystrophic, layering calcification, suture. Round is not typically benign always. It depends on the distribution and the evolution along time. And the suspicious morphology, which you know, the amorphous, coarse heterogeneous, fine pleomorphic, and fine linear branching. Right. Let me ask a random person here. بدر المناع R4 KMC. بدر. ما في بدر. طيب أحد من المجتهدين؟ أي أحد؟
السلام عليكم.
عليكم السلام. جوهرة.
I would say my answer would be by magnification views.
أيوة, which magnification views? When you which level are you, جوهرة؟
R4.
أنتِ جوهرة متخصصي ولا someone else؟
أيوة متخصصة.
أهلا جوهرة.
أهلا.
طيب لما تجيك التكنولوجيست وتشوفين screening mammogram أو توريك magnification view, which magnification views? She magnified the image. بتقول لك
mammographic magnification.
صحيح, magnifications, which views? زي اللي عندنا CC و MLO صح؟
CC and ML, true lateral.
صحيح, CC and ML. It's very important that we have CC and the lateral, both of them. It's not enough that you magnify it on one view. If you see calcification on one view, try to find it on the other view. Sometimes it's very faint and it's difficult, and we will go with one view if we can't find it. Ideally, we try to find it on the lateral view عشان لو صار في layering خلاص this is benign. بس إذا we can't find it, which is sometimes يعني it's not uncommon, we can do the magnification on a view. طيب appropriate views, describe the morphology and measure the extent. It's not enough that you say that you describe the morphology, you have to measure it, because if it turns out to be malignant, you will be already providing the on-call or the surgeon with the extent of disease. Measurement is essential. طيب إيش رأيكم في هذا الكلاسيفيكيشن؟
Needs further imaging.
I agree with you. هذه موجودة شفناها أو شافوها هم في screening، بس طبعا هذا zoomed out أو zoomed in. المهم كانوا هنا يحاولوا شافوها في التوموسينثيسيس، وفي التوموسينثيسيس أنا ما أدري مين منكم عنده توموسينثيس سلايسز، بس في التوموسينثيسيس هذه كانت موجودة على image number 7 out of 40. They were suspecting that this is a superficial calcification, meaning it could be a skin calcification. What do you do? So هنا ال MLO image number 3 or number 7, it shows you that it's at the periphery of the mammal of the tomosynthesis slices. So you wonder if this is skin calcification أو لا. You do this view. What's this view?
اللي هو tangential view.
أيوة, tangential view.
Just to see if it's actually superficial or if it's like a skin tattoo or something. Like on the
it will tell you if it's skin calcification أو لا, or if it's superficial calcification أو لا. These are skin calcifications. They frequently have a radiolucent center and they appear in smaller groups. But sometimes they mimic suspicious calcifications at mammography. And they may not appear on the first and last slide of the tomosynthesis, meaning they will be, you need to do a problem-solving exam to define if these are skin or not. And what you said is right, tangential view. How do we do tangential view? طيب هنا زي ما قلت لكم قبل شوي
I think it's through ML. I'm not sure بس يعني it's like an ML.
هو tangential it doesn't matter which view you're taking it, whether ML or لا. You just need the beam to be, the X-ray beam to be parallel to the area of the skin lesion. Whether it's CC or it's ML. فهنا this is just to show you في tomosynthesis. في tomosynthesis عندنا so many slices صح؟ فهنا مثلا for example this star, it's an area of skin lesion. If you are going through the slices and this skin lesion is not touching the paddle, you will not see the calcification at the first or second slice. You will see it deeper and you wouldn't be sure if this is skin or not skin. فعشان كذا it's not always accurate. طيب كيف نسوي tangential view? We'll CCC will MLO, we will select the closest surface to the calcification, and then we will place a grid. If you have done preoperative localization, you will be familiar with the grid. We call it the alphanumeric grid. بعدين we'll take an image with the grid and we will put a BB marker on the calcs, and then we will do the view, the tangential view. فهنا this is an example. فهنا في arrow I can barely see the finding, but there were calcifications, and then we put this grid, the alphanumeric grid, and we put the crosshair on the area that we want. On the computer we will choose where we will place the BB marker. فهنا عطاك الكروسهير على الE وعلى 10. We will go and we will put the BB marker exactly at that area. And as you can see, the BB marker at the area of calcification. And then you will place the BB marker to make it perpendicular to the paddle. And when you put it perpendicular to the paddle, you would like to have the X-ray beam angled or parallel to the BB marker, and you will see if it is at the surface or not. فهنا calcifications, they were not at the surface. You can see they are deep and they are confirming that they are intraparenchymal. As a resident, you don't need to know how the details of how to obtain it, but you need to know that it's a tangential view. It can help classify superficial lesions. Other typically benign calcifications are rim calcifications with a radiolucent center. They can be seen with oil cyst or fat necrosis. They're not always this pretty. They can look ugly. They can have what looks like asymmetries with them, thickened wall, and dystrophic appearing calcification, similar to this case, which is in multiple sites. Okay, this is another patient with a palpable mass. مين يبغى to analyze this case? نوار ايش الاجتهاد هذا ما شاء الله. غيرت رأيك؟
فتحت المايك تتكلم. هل أخذها ولا أنصب شوي؟
إيه لا خذيها.
Okay, so I'm presented with selected images of ultrasound showing an oval parallel mass with heterogeneous. Seems that it's well circumscribed with some areas showing posterior acoustic shadowing, likely representing calcifications.
Okay, good job. طيب وش بتسوين؟ How will you confirm? You said likely calcifications.
أيوة, I would go back إذا عندها prior mammos to look for calcifications.
ممتاز. She's 50. فإذا أحد جانا 50 وعنده palpable concern we do mammogram. بس أنا قلت لكم خلينا نجيب ultrasound first. بس أنت you want to correlate it with something else. عندها prior mammogram. What do you think this will be?
Calcifications.
صحيح, calcification. You have a mammogram.
Okay, and so it's chunky grouped calcifications. I don't see any other lesions. It's in the posterior third central or mid third.
هذه chunky, what do we call it?
A popcorn calcification.
صح, popcorn. هم حيغيرون ال popcorn terminology. You can say popcorn, or you can say coarse. Not coarse heterogeneous, coarse, which is different from coarse the coarse heterogeneous is the suspicious form. So هذا coarse calcification وهذا BIRADS 2. في rare cases they present with, as you said, chunky calcifications, and they turn out to be, for example, osteosarcoma, but these are extremely rare. فهذه with the ultrasound findings are fibroadenomas. You don't need to further investigate it. Sometimes with fibroadenoma, they do not present as well as this picture. Sometimes they end up being biopsied because they look more coarse, heterogeneous than being only coarse. They have different shapes. This is a patient who had a mammogram, first time screening, and they did magnification views. And on this magnification view, you can see that there is a group of calcification. Do you agree? Do you agree it's a group or no?
Yeah, but different size and shape.
Yeah, the majority are round, صح? You can say round and punctate. Punctate is a subterminology of round. فكلهم similar shape of different sizes, but it's the same shape. These are round calcifications. Command punctate is one of the terms that may be removed. You can use punctate and round. And in a first time screening, classifies for a BIRADS 3. في specific criteria for this presentation of calcification. If there is a solitary group of round calcification on a baseline mammogram, this is BI-RAS 3. And you have, when we say BI-RAS 3, does not mean that you give it BI-RAS 3 on the screening mammogram. You have to call the patient for additional views, which are the magnification views. On the magnification views, they qualify as the description we just said. They will be a BI-RAS 3. طيب مين يقول لي إيش يعني group؟
3 or more calcifications.
3 or more specs, you mean?
Five, I think five.
أيوة. عندك minimum of 5 calcifications
Yes.
within what?
1 centimeter.
صح, within 1 centimeter, and the upper limit of 2 centimeter. We have the suspicious calcifications. When we say amorphous, means they're hazy, powdery, indistinct, coarse heterogeneous, irregular, smaller than dystrophic, fine pleomorphic, different shapes and size, smaller than coarse heterogeneous, and fine linear or fine linear branching. By degree of suspicion, fine linear or fine linear branching is the most suspicious, and it will be classified as 4C. As you mentioned, grouped, minimum 5 calcifications within 1 centimeter and upper limit of 2 centimeter. Regional, when we go regional, they're more than 2 centimeter, but they're not conforming to a duct. When they're conforming to a duct, they will appear segmental. Overall assessment of regional, the term regional usually is not suspicious and more of describing a benign thing, but assessment will be based on the morphology and the distribution. And we have linear, which is suspicious because of it implies that it's along a duct, and segmental, which means going towards the nipple in a segmental distribution. Now, if you have different suspicious classification for the sake of differential, we will do biopsy. There will be BI-RAS regardless of the results, path results. But if someone asks you for differential, for example, you can say fibrocystic changes, post-traumatic, fibroadenoma, etc. Atypical lesions such as ADH, ALH, or malignant lesion, and this is what we want to rule out. طيب الحين جاتك patient أو شفت suspicious calcifications. Genetic technologist to check with you. What will you do?
So it is a suspicious calcification by RAD 4 means we need a stereotactic biopsy.
أحسنتي. طيب the patient wants to talk to you. طبعا whenever you have the chance to talk to the patient and tell her about the results عشان يعني kind of تطمنينها أو she doesn't get surprised when she leaves the hospital. بتقولي لها تروحين البيشنت, you'll go talk to the patient and tell her that we have these calcifications, they're indeterminate. Most of the calcification we biopsy are benign, but we need to do a biopsy. طبعا if it's very suspicious and she insists, you can tell her that the level of suspicion is higher. You tell her about this recommendation and she asks you, how do you do the biopsy? Briefly, how do you do the stereotactic biopsy? Or the biopsy in general for the calcifications? For example, this is a patient, you did the magnification and you see these calcs. كيف حتقولين للpatient? Simple terms. دلال الحربي. من بعد دلال؟ داليا الشاعر R3. طيب يا جماعة ترى عيب و disrespectful to yourself إنكم you don't talk. It reflects poorly on you. إذا بس you come for the attendance, or I don't know how it works out, the attendance, بس for your attitude. طبعا most of the ones I called are people I don't know. For your future lectures, try to work on this attitude because it's not acceptable. Leila, you raised your hand. أو لميس, I'm sorry.
ممكن أخذ الحالة دكتور؟
بس اشرحي لي كيف بتقولين للبيشنت how will you do the biopsy.
هو تكون biopsy stereotactic.
The other option. Sorry, Leila, which year of residency?
R2.
Okay, ممتاز. Have you done a stereotactic biopsy?
أيوة. Yes. To be stereotactic guided biopsy.
ممتاز.
Application. بعدين نعمل لها imaging to confirm with the group calcification.
Okay, ممتاز. طيب. هتشرحي للpatient according to the hospital that you're at and the tables that you have at your hospital. There are more than one table. For exam purposes, try to memorize the steps step by step. For general life encounter, you will tell the patient that you will be, if you have this table, which is a great table, they're lying down, they don't see anything, we call it the prone table. The patient will be lying, the breast will be hanging, and we will compress the breast. If not, you will tell her that, for example, she will be sitting, or she will be, depending on the system you have, and we will compress your breast. We will give you, we will see the images while your breast is compressed. We will localize the area that we want, and then we will give you freezing, and we will go with our biopsy device, take some samples, and after we take the samples, we will assess the samples if we have enough calcifications. If not, we may need to take extra tissue, and then we will place the clip, and then we will take an image at the end. So this is just the steps in simple terms. So you said stereotactic guided biopsy, but there's more than way to biopsy the calcification, which is the tomosynthesis guided biopsy. The difference is that in tomosynthesis, as you can see here, this is tomosynthesis slices. For example, this is the target, which is the star area, the calcification. You take tomosynthesis image in one direction, and then you will scroll to see where the target is. And the thing that you mentioned, the other way, which is the, I think, more widely available and common throughout the world, is the stereotactic guided biopsy. And in this technique, you will have a scout image, which is the image that you will see you'll take at 0 degree, and then you will move the X-ray tube 15 degree above that and minus 50 degree below your scout images. So this is the scout images. This is what you want to take. And then these are the two images for the angled projections. And you will choose on both images where the lesion is, and it will show you where it is on the scout images, and the machine will do the rest, similar to the tomosynthesis. So if you have, you don't have the benefit of the prone table, this is what a standing technique looks like. sitting technique looks like. You'll freeze the area, and then you will advance your needle. And after you advance your needle, you have to take a picture. And when you take the picture, you will confirm that you are at the right place with post-procedure images, and then you will take the samples. And then after you take the samples, you will image the sample while the patient is still in that position and the needle device is within her breast. Because if you're not getting enough calcifications, you might need to go and either retarget, meaning choose a different target, or you take more tissue from the same area. So this is how you assess the calcification. They are satisfactory, and then you will place the clips, and you'll confirm that the clips is in the same place. And here you'll take an image. Later on, you can see that there are post-procedural changes with air and hematoma, which is expected and within the acceptable. Okay, I think we're done with calcifications. We'll just go over some cases. So the first one. "40 female with left breast lump and pain to rule out malignancy." في حد متحمس؟
Can I take it?
لميس ولا ليلى؟
Lamis.
Okay.
So I'm presented with selected images of left breast mammogram, MLO and CC views. I can see that there is a large hyperdense retroareolar mass with extension to the nipple, as well as I think there is some nipple retraction. The mass is partially obscured by overlying fibroglandular tissue. And
ايش يعني partially obscured? Partially obscured يعني we either use circumscribed or obscured. Circumscribed meaning more than 75% of the margin is visualized. If more than 25 is not visualized, we can call it obscured. And obscured means that there is adjacent breast tissue that's obscuring visualization. But here, the posterior aspect is indistinct. But if you see it on the MLO, you can say that it goes to the nipple base. ايش رايك؟ ايش حتسوين؟
I would order ultrasound to assess the mass and possibly put a label as BIRAD.
As what? Mathematics, Lamis. You'll put label as what?
BIRAD 4.
Okay, طيب هي جاية diagnostic. We should do the ultrasound at the same setting. Let's say السيستم عندنا شوية ما هو مضبوط. It is very suspicious. You need to call the patient back. You can call it by RADS4 just to expedite the workup. But generally, for such a case, ideally, in a perfect world, you will have the mammo and the ultrasound done at the same setting. Thus, similar to what you did, patient ما سوت ultrasound at the same settings. She came later, and this is what we did. And we can see the ultrasound findings. ايش رايك? You want to continue or someone else, Lamis?
I can see that there is an oval hypoechoic irregular mass seen with some angular margins. And maybe there is a focus of calcification, but I'm not sure.
Okay, طيب قلتي oval. Okay, good job. المارجنز ممكن تكون indistinct. ففي الشيب عندنا هو يعني عندنا يا oval يا irregular. في الشيب you can't draw the shape, the wall of it, صح؟ It's not clear. You can call it indistinct. هنا قصدك ممكن يكون angular. okay. هذا بس الوال أحيانا حتى في السيست إذا كان in between cystic spaces يطلع some question that. فالسايز حقها 1.6 وهنا كم أنا ما في دوبلر بس adjacent. هنا كان larger صح؟ يعني ممكن هنا 4 centimeter.
Exactly.
عندك differential.
And maybe if there is history of trauma, this could be a hematoma that is resolving.
Okay, exactly. The patient had a history of findings of mastitis to rule out underlying malignancy. She had a mammogram at the same day where she had the ultrasound, not for the mass itself, but they described some asymmetries. So you can see that the mass a few weeks later has decreased in size. And when you go examine the patient herself or when you read the chart, she tells you that she's been on antibiotics for a few weeks. So you have a diagnosis of
abscess or collection.
You have a diagnosis of breast abscess. You still need to recommend short-term follow-up until it further subsides, just to rule out a superinfection within malignancy. But patient came later and she had almost near resolution of this finding. So there is nothing to worry about. Okay. Fatma, are you still here?
Yes.
فاطمة وش رايك بالكيس؟ هذه جاية
والله تشبه حالة شفتها يعني من يومين أو 3 أيام تقريبا. هذه سكن.
ليش سكن؟ أول شيء
لأنك
هذا
قلتي
let's
لي.
explain the views. هذه عندك left MLO و left CC بس أنا عشان you see it better I zoomed it out.
لأنها في نهاية الكت ولأنك قلتي لي إنها سكن فهي سكن.
أوكي. طيب شكرا على الشرح.
كانت في الطرف صح؟
طيب هنا في التوموسينثيسيس it was on the inferior slices number 5 صح؟ it's at the center صحيح؟ it's round. وهنا في MLO it's going along the inferior aspect. في MLO ما كانت على الطرف. فكان الكلو in this case إنها كانت she had a reduction mastoplasty or mastopexy. فهم along the scar line, if you see images for how they do it, one of the techniques or the most common techniques that we see is that they have a vertical line along the inferior aspect from the of the breast, going down from the nipple, and then they have a horizontal line. But this line over here goes with the scar line. These are skin calcification related to areas of scarring, which is common to have calcification in those areas.
دكتور عندي سؤال. هل لو إنها ما هي بالسكن أو لها يعني قصدي ما كنت أعرف إنه مثلا في هذا السيرجري هل هذا تعتبر segmental؟
لا هذه مش segmental. هنا you can call this one grouped, this area, but you need to magnify it to see if it's within the description of a grouped ولا لا. فهنا if you take only this area it will be grouped. هنا هذه النقطتين
بعيدين.
أي ما فهم it's not حتى if it's intraparenchymal given the morphology they're of low suspicion.
Nice شكرا.
Okay.
Yes.
طيب this is similar. Here the more classic appearance of skin calcifications, the one that we usually hear about, the lucent centered and these are in the periareolar region. This is a patient also who had some sort of reduction. Around the scar area, there is these calcifications. These are one of the typically benign calcifications, skin calcifications. Okay, what is next? Okay, هذه الcase. Patient had screening. There's this image and this image. Raikum.
Yes, can I take this case?
Mm-hmm.
Okay, so this is magnified spot compression mammogram. There's multiple microcalcification. It seems of different sizes. I think it is like polymorphic calcification.
Okay, with you.
So I will go for ultrasound.
طيب هو الcompression additional views we call them magnification views CC و ML. Spot compression is different. صح we do the same thing إنه في ذات area we spot that area of a breast بس التكنيك is different. هذه magnification. فنقول magnification views CC and ML polymorphic classifications. والnext step
دكتورة قطع الصوت ما سمعت.
مين ما يسمعني؟ تسمعوني الحين؟
ايوه نسمعك الحين.
طيب قالت لنا زميلتنا polymorphic classifications, good description, قالت for ultrasound. Do we need to do ultrasound? And why do you want to do ultrasound?
I want to see if there is underlying mass. If there is underlying mass in ultrasound, we can do ultrasound guided. If there is no mass, I will do stereotactic biopsy.
Okay, هذا good plan. عادة يعني ممكن تكون هنا في asymmetries, we can try to find it by ultrasound. Yeah, it will be as an extra step. I think with the practice and with the tissue composition, you will know which calcifications that you will likely see on ultrasound and unlikely see. For a grouped calcification, you will not see them. There is a high likelihood that you don't see them on ultrasound, but it's not wrong to try just to save the patient the steps of the stereotactic biopsy. يعني with these findings, it's maybe unlikely, or it's hard to see them. You can maybe, but it's hard. And sometimes if you're not confident that you are seeing these calcifications, it's better not to go biopsy them under ultrasound عشان you don't make the patient come twice for 2 biopsies. One of them was not necessary. Yeah, this is very suspicious calcs. I don't have the result because the biopsy was not done yet. 50-year-old with prior lumpectomy referred for biopsy of suspicious calcifications. In a prior, in a current, patient had surgery for the lumpectomy for prior cancer. What has changed? Anyone? You don't need to describe the case fully. Just tell me what has changed.
I think it's started more coarsening.
صار في more calcification.
وعددها زاد yes.
Around the surgical site, there is more. It's more prominent now, or it is increased.
Calcification.
Change it.
Okay, I agree with all of you. There are increased calcifications, and this is the CC view. You can see that the calcifications have also increased on both views. Do you appreciate this, or do you want me to point it out? The radiologist requested magnification views.
So there is a group of dystrophic calcification associated with conjunctional, with the architectural distortion, as well as disruption of a skin layer. So all these are post-surgical changes.
Okay, good job, Qadir. And the thing is, this patient was referred for biopsy of this calcification based on this single lateral image. As we saw here in the CC, we did magnified CC view, and you can see that these are along the skin area, and there is some lucency in the center, and they're along the periphery. So these are in keeping with dystrophic calcification / fat necrosis, so we do not biopsy those. Okay, maybe this is the case before the last. Yeah, the last case. 60-year-old axillary fullness. So these images do not project well. So you can try. So this is left axillary ultrasound. And we're trying to measure a lymph node. Tricom.
الكورتكس حقها thick و it's nodular يعني مو مرة شكل التبكال benign lymph nodes وفيها زي فصائل ايكوجينيك
صح عليك. فايكوجينيك foci. These might represent calcification, صح؟
Yes.
Calcifications in a lymph node.
Suspicious?
Suspicious, you need to look for a source, صح? You know that you have the differential of the left calcification. عندكم الأشياء اللي we read but we never see, the gold therapy. I don't know if it ever exists now. Granulomatous diseases. Thus, if you see this in the axilla, you need to assess the breast because it is a suspicious finding, and we don't describe them usually in the axilla as the same morphology as the breast. They're usually suspicious, but we need to look why there is these echogenic foci or these calcifications. What do you want to do next, Fatma?
أنا قد شفتها بالمامو يعني ما أدري أحس بشوف أول شيء مامو إذا في calcification يعني ماس.
ما قد شفتيها في حسبتك
صادق. لا أنا أقول يعني هل سوينا مامو قبل؟
It wasn't visualized on the mammogram.
يعني ما في suspicious microcalcification. أقدر ممكن أحس أسوي screening breast ultrasound أو إني ما أدري go biopsy على طول هذه lymph node إذا ما لقيت
يعني. You need to look for any suspicious finding on the mammogram because usually if there is metastatic calcification in the lymph node, you will find that the original cancer has calcifications. في الماموgram, this is the mammogram. What's the diagnosis?
صراحة شكله suspicious يعني في speculation في two group actually ما أدري في retroareolar وفي outer upper outer yes
with associated
asymmetry و distortion.
وهنا عندك the index speculated mass causing retraction of the nipple with suspicious calcification reaching the nipple base. Healthy patients based on the mammogram.
أعطيها 4.
Oh, this is 5 breast cancer.
Okay. Nice, yes. صح.
Calcification is in keeping with metastatic lymphadenopathy. The patient underwent biopsy, and the one who did the biopsy took an extra step and imaged these axillary specimen to show you the calcifications. that were in the lymph nodes. This was a case of suspicious calcification, but in a lymph node. This is the final case. And do you have any questions?
يعطيك العافية. شكرا.
العافية دكتور.
يعطيك العافية دكتورة.
شكرا جزيلا وشكرا لحضوركم. مع السلامة.